I have participated a number of times in different conferences in Latin America. I believe it is interesting, so I know the region. I think it is interesting to make some comparison how the healthcare systems and particularly radiotherapy is organized. So I used some data from the Astro Hero study, and I also did my own study on that. So this is what I'm going to show. Let me. So key point to be discussed is radiotherapy and eastern part of Europe. So hypothesis or question is whether certain factors like economic development, historical social factors, organization of a healthcare delivery, type of reimbursement, and epidemiology have impact on quality of radiotherapy and access of radiotherapy, and a number of factors has to be evaluated. So I know American system, and particularly South American system, is different than most of European systems, and in Europe there is also diversity. The first point to be to be taken in mind that in these countries that I'll be talking about is most of the system is public. The private system supplement public system, so the major player in fact is state. So if we are going what is East Europe, so if you look for the political map of Europe and the geographical distribution, so you see, let me, the point. Okay, this does not show. So, but you see on the right, of course, the Russian Federation takes most of the east part of Europe. There is also Kazakhstan and Georgia. But we need to limit discussion, and normally if we are talking about East Europe, we consider European Union and is east part of this. So it looks, now it's, the map is limited to half of this, what in really is entire Europe. You can see in green some, this is map and division done because of the currency. So part of Europe uses a common currency, which is euro. Certain countries did not switch to euro. So this is one of possible division. But normally when we say East Europe, we refer to certain period in history after Second World War, after 45 till 1989. There was an Iron Curtain, Germany was divided. So in east part of present European Union, there was a system which we called real socialism, or based on communism, whatever we name it. So you see in the pink color certain group of countries which somehow were linked to former Soviet Union. This of course remain, this stopped in 89. So the question is how we can say what is European Union today. Sometimes it's referred to a group of countries: Bulgaria, Czech Republic, Hungary, Poland, Slovakia, Croatia, and Slovenia. You still see them in pink color, but there are some bias in it, because on the red you see Yugoslavia, former Yugoslavia, which also belongs somehow to this group. However, it was not dependent to the Soviet Union, but had the same political and economical system. So the question is whether this period of time, only 40 years, can affect, 44 years, can affect so much development of a country and its organization, that even despite of a 1,000-year history that was different for these countries, can really impact on current organization of healthcare. So I put on red color a question that 45 years of so-called real socialism really changed a lot in these countries. So even despite of a long history before, they have common properties right now. If you look, so a question also is whether if you look for Bulgaria, it's in fact so. So Spain is also so in the meaning of the altitude geographical. So this is the same. So however, we reserve the term east for the countries which lie even south, but are more east. So that's so the only objective factors that links all this group of countries is this joint common period of 44 years in the same political system. So for the purpose of this presentation, I included Bulgaria, Czech Republic, Hungary, Poland, and Slovenia and Romania, despite there are some differences between. So this looks like, so it's a significant part of Europe. So now we discuss in detail this particularities, let's say. The particularities, the main denominator was this political system called real socialism. So it was linked to limited freedom in market economy. Most of the industry was owned by the state. Also in agriculture, there was central planning, limited political freedoms. You may say it's many countries worldwide. Of course, such system exists, but there are certain particularities in this region. It changed structure of the society because it assumed universal access to healthcare, education, and employment. And in fact, social differences in the meaning of wealth decreased. But the system has many poor sides, and finally it failed. It demotivated people and did not reward for better work or for more efficient activity. So in consequence, the economic growth slowed down during this period. After 1989, free market economy was restored, political freedom was restored, so most of these countries are now normal, let's say, democracies. However, certain particularities remained. There is also assumed universal access to healthcare and education, although some restrictions apply. So now we look how it looks today. It's all these particularities are grouped to study categories. Since 1989, market economy in some places was even more liberal than in traditional West European countries. After 1989, GDP or Gini, so it's general national income divided by capita, have been growing, and it's closing up to the rest of Europe. So this is a situation which is observed. As far as epidemiology, I would stress it, there are small differences in incidence, by bigger in the advancement of the disease when detected and the time when treatment is initiated. So you will see more in the graph a little later. Historical and social factors, so before was central planning, limited democratic freedom. However, certain aspects remained. There is tendency to organize main aspects of healthcare on a national level, and it remained. So in most of these countries, healthcare is organized on a central level. So very few particularities in the regions are observed. As I said, there was assumed universal access to healthcare. So in the meaning of coverage, so it's legal parameter, almost everybody is covered. This is the same for the education. Very few restrictions apply. If you want to choose a second specialty, then sometimes you have to pay for it, but basically education and healthcare is free. Reimbursement in radiotherapy is a part of a national healthcare system, but so it's universal also legally, but between countries significant differences are observed. So if you look for the health expenditures, this is not nominal value, it's just percentage of the general of GDP. So you see countries like Poland give less percent of general domestic product to health than Spain, and on average on the world. So that in practice means access is universal, but people have to pay a certain portion out of the pocket. So everybody is covered, but in many countries, but some supplemental payment is required in many procedures. Not in the big hospitals, but in many other services. Very interesting graph, so-called cluster analysis for European countries done by the group of Hero, Yolanda Livins and others. You can see this is correlation between equipment and personnel related to gross national income. So you see most of the countries of the region fall to the first on the right cluster. Czech Republic is in the second cluster. And there are certain differences, but however, this groups, this shows and confirms my thesis that this region have certain particularities, and organization and access is somehow different than in other groups of countries. If you look for the incidence, so this is just incidence. So again, what is Europe? This is intentionally set Central East, which more or less refers to the group of countries which I'm talking about. Of course, it's somehow different than North, South, or West. But not very significant differences between these countries are observed. This is females, five pathologies shown. When, of course, you can count epidemiology indicators and or patients in different ways, but if you look for the just for numbers of patients treated by radiotherapy and divide by population, you see a fraction of between 109% till 103%, but it says almost nothing. It's just raw factor. We need to go to more details to be able to evaluate, and this was done by the papers of Josep Maria Borràs and others from the Hero group. So we were able to count so-called optimal number of courses in radiotherapy for all pathologies. It's not just utilization rate, it's what should be, not only by the incidence, but should be taken something more into account, like staging and the time when disease is detected, so it affects staging, and so that's more complex model. So you see, in all of these countries, the actual radiotherapy courses, the figure is less than it should be. In the meaning of percent, this is last two columns. Optimal radiotherapy courses percentage of optimal is between 63 and 93. So it's significant gap. So a lot of population is not served with radiotherapy. This is spread for different pathologies. So it's optimal utilization of radiotherapy, meaning what should be, considering not only incidence but also staging. So very particular situation in each country. And you can see some differences between countries, not much. I just highlighted in colors breast, lung, and prostate. If we are looking for staffing, and saying what is quality of radiotherapy is different. It's very complex. It's not easy to say. Let's say we can look for the education of staff. In all these countries, the access of education is free. It's possible. The duration of training, duration in oncology and medical physics, however, differs significantly between these countries. So the target, I think the target is 5 and 4. 5 for radiation oncologists, 4 for medical physics. That is a target some countries got into, some others still not. This is this study done, another study, number of accelerators per million inhabitants in west and east part of EU. So if you look the difference, the Czech Republic, which is on east side, have the similar to Germany, which 5.4, 5.5. All other countries, you know, there are differences, just to say. If you look not in the meaning of megavoltage unit absolute values, so Poland is the largest country in the region, so but that says with the largest population, so that is why it dominates, but just only to show. Now we are going to result phase, so impact. As I said, coming to access to radiotherapy, currently in all presented countries, healthcare, also radiotherapy, access is more or less, I said, universal, everybody is covered, this is legal term, and private insurance is limited. Although exists private sector in radiotherapy, it exists in almost all disciplines in medicine. Private hospitals or clinic may, in some countries, an example is Poland, compete for the reimbursement from national health funds. So the difference between public and private hospital is that public hospitals cannot treat private patients wishing to pay. The private hospitals can choose from both part of cakes, can have a contract with National Health Fund and also can see private patients paying for the service. Geographical deficiencies in access are noted, and I will show it on another slide. Okay, it's, let me go back. No. Okay, the geographical differences are noted. We did a study that if a driving is more than 1 hour, people normally do not consider radiotherapy as the best option because it's a long-lasting procedure. And if required utilization rate for Poland, for example, is 53, so in remote regions, this is below 20. So this is a factor which, despite of legal coverage, impact access. Just an example for Poland, this is the access to healthcare which remained, in fact, for all the time is written in the constitution. So citizens are granted equal access to the publicly funded healthcare system. Just interesting calculation for optimal utilization of radiotherapy in Europe, which is what should be, of course, for the chosen countries in the region, coming from Boras and other HERO study. So you can see the optimal for Czech Republic is almost 90, while the very interesting result, because on average for worldwide is about 50. For Poland it is over 60. So this is because of the staging of a disease detected. If you look for example of Poland, so with darker color you have better utilization rate. With lighter you have worse utilization rate. And because in the middle of these subregions there are cancer centers located, so you see that the distance from the hospital really have an impact on the utilization rate of radiotherapy, so in fact for access to radiotherapy. Conclusion on utilization led global figure like 50% for all patients that require radiotherapy do not take into account the variability. frequency of tumor sites, and country of stages and diagnosis. Actual utilization rate for radiotherapy in East EU is below optimal as revealed in Astro-HERO studies. So that's fact. Quality is a difficult parameter to be evaluated. Of course, we can see for staff its education, equipment, regulations. However, in the studied region, educational component is linked to historical background. This is basically its accessed. Differences in postgraduate training are noted, and differences in regulation enforcing quality of care are also noted. So I'm coming to conclusions. That radiotherapy capacity in Eastern Europe has common properties, which are rather universal access to radiotherapy in the meaning of legal term, due to historical social factors, which include regulation coming from central government agencies, is uniform for a country, organization of a healthcare delivery is uniform for entire countries. There is similar epidemiology in the term of incident, but difference in detection time, staging, which involves different optimal utilization for radiotherapy. Various types of reimbursement in radiotherapy are seen. Radiotherapy the meaning of economy is placed in the same cluster and not the same for Czech and Slovenia, but very close, of the staffing equipment versus GNI. That means that is the direct relationship between access to radiotherapy and economic development. Quality when delivered, so it's done, measured by complexity of procedure and staff education is more complex matter, and diversity is observed. No direct conclusions can be drawn. I'd like to go to acknowledgement. So first of all, you see the Astro-HERO group, head by Jolande Levins and Kai Grau, and I was between this group also. We published a number of papers, about 7 altogether, so you can see them in a PubMed, most of them in radiotherapy and oncology. I also did my own study and did a survey for the purpose of this presentation in September 2010. I want to thank the colleagues from different East European countries, shown here. There is also a study done by the Polish Society of Oncology on the status of access to therapeutic healthcare services, including radiotherapy analysis and recommendation, which are also absorbed certain data. Lastly, I want to show the city, 3 slides about city and Poland. So the Greater Poland is the region in Poland. It's a historical city in Poland, first capital but the last king resided there in 14th century. Then it moved to Krakow, and then it moved to Warsaw finally, where it's here. But we still have a castle, King's Castle. This is Greater Poland Cancer Center, established in 1953, which I had. Another view from another side. So thank you again.